Introduce Dr. John Vierling while we're waiting here. He's a tenured professor of medicine and surgery and chief of hepatology at Baylor College of Medicine in Houston, Texas. He's also the director of Advanced Liver Therapies, a clinical research center for new therapies in adult liver disease, and program director of the Hepatology and Liver Transplant Fellowship. He graduated from Stanford University, as well as biology, as well as the School of Medicine. And I also wanted to mention that he is one of the top 1% physicians rated by the U.S. News and World Report. He's going to be addressing overlap syndrome. So we'll hear a little bit more of that with Dr. Vierling. And I'll pass you that. Did you want the microphone apart? No, I think it'll be fine. You want to stand here? Okay.
Come over to the side.
Okay. If you want to take it out, you can as well.
Well, good morning to the PBCers. It's a terrific opportunity for me to be here. It's a real honor. I have been to countless meetings of this organization, and I have tremendous respect for all of you and what you're afflicted with and how you have banded together to make such a difference. You were and have been and will be inspirational as well as informative in your participation in clinical research. Without you and your participation with Eric Gershwin and Keith Lindor and myself and others, we would never have been able to publish the demographic information about risk factors that we did in two separate landmark studies. And you were the source of that because of your dedication to helping us understand this disease. Now, with everything that was said that I do, that is a code for being old. So, and as I like to say, being old beats the alternative, obviously. So I will take that. But being old, I think back to the first patient that I ever saw and worked with PBC, which was 1974. And going forward, that particular patient devoted my thrust of interest into this disease and the research arena of the immunology of the disease, and that began at the NIH, and it has been really instrumental in my own career because I'm interested in the immune mechanisms that go awry in autoimmune diseases, as well as diseases that we try to treat, such as prevention of allograft rejection or graft versus host after bone marrow transplant. And what I want to discuss today is, I think, an important topic because we still do not have a complete picture or the complete answer. But we appear to be sort of spinning along, unfortunately, as if we do. So the first slide I have here depicts at the bottom the artist's rendition of what you might see as a double helix of the brand new TMC3, and over to this side is the brand new Baylor College of Medicine Hospital, and this is what those that are from this area know as the Texas Medical Center, which is now an addition that will make it even much larger than the largest medical center in the world. And these are buildings that are going to be devoted to pioneering research and bringing small pharma and nascent ideas into space where they can be supported in that next step of development. So I again get back to this issue of research. But on to our topic. Autoimmune diseases have some commonality. And although we don't know every detail, we kind of know the big picture, which is on this slide. We have genetics involved, and those genetics we'll talk about. We have your immune repertoire. What do I mean by that? Well, you know, if you were an identical twin, after birth, your genetics are identical. Your environment is largely similar, maybe not absolutely identical, but you may end up making an immune response to something in your environment as twin 1, but twin 2 made at the same time an immune response against something else in the environment, and then later doubled back and made that response. The sequence in which you're building that immune response, which culminates in your adulthood and thereafter through immunizations and diseases that you're exposed to, makes a difference. So certain repertoires make a difference. Now, you've probably heard already that if you happen to grow up where you're sleeping in the barnyard and you're kind of breathing dusty manure and have mold and everything else as an exposure, that you tend not to have, as an adult, autoimmune diseases. You tend not to have allergic immune diseases like asthma and eczema. And it is a hygiene hypothesis, and it has to do with this immune repertoire. Then, of course, you have immune regulation. Now, our immune system is just built to recognize something that it needs to do battle with, to respond to it, and to remember that. So recognize, respond, remember. That's how we're built. Now, we once thought you had to recognize a pathogen. Well, we now, like a bug or a virus or something that is like a transplanted organ that's foreign to your cell, we now know that cells can start this whole process by recognizing danger in their environment, stress in their environment at the cell level. I don't mean stress that we would feel and perceive as stress. And so with that comes the ability to shut it down. Now, if I fight influenza, which I did last year, and I never shut it down, I'd be sitting up here like one big lymph node filled with all the cells that keep on developing to fight influenza, which is long past. That's the immune regulation I'm talking about. Turning on and turning off. Autoimmune diseases turn on, but they don't turn off. And they perpetuate as if the reaction is something that the body needs to do for its survival. And then finally, you have the environment, the environmental exposures that all of us have. Well, they obviously then interact with your genetics, your immune regulation, your immune repertoire, because this is generated by your environment. And culminating in this is this risk, when all those things are just right for a small subset of patients, that they're going to have an autoimmune disease. Now, we know a lot about those genetics, starting with the fact that we're supposed to recognize ourselves as self and get rid of any cells, permanently get rid of them, as we are maturing as a fetus and in young post-birth life, to rid ourselves of them. But we now know that we actually don't do that most of us have the ability to react against self. And the question then becomes, why do some actually react against self and others don't? And why is it a minority that do? We know that the major histocompatibility complex is a place that is associated with autoimmune diseases. In PBC, we know its association. It tends to be a weak association. It's not probably the driving force, but nonetheless, there is a particular HLA type, which is what we call the human major histocompatibility complex. We know that immunoregulation is genetically based, and we know that things that home to the liver, what we call hepatic meaning liver, trophism, is involved. Environment, we know a lot about, and we know that infections induce this repertoire. We know that xenobiotics, which are drugs or herbs or environmental toxins or pollutants, anything your body takes in is going to be processed to get it out of the body. And the major processing place in the body is the liver. That's how we handle everything that you take. And that's why your liver specialist or your gastroenterologist warn everybody about being careful about what you take, especially issues of herbals, because we have abundant evidence emerging now that what the herbal says it contains, it doesn't contain, or it's contaminated with things that are not on the label, and this has led to a lot of misadventures. So that's what I mean by xenobiotic. And then we have the liver's microenvironment. What actually goes on internally is largely known to be important, but is still misunderstood. So now I've narrowed it down to this little group here is having autoimmune hepatitis, primary biliary cholangitis, or primary sclerosing cholangitis, the three autoimmune diseases. Now, stalking all of this is our microbiome. Now, the microbiome is defined as all of the organisms that are not part of your genetic code. And I'm not talking about just the gut. You probably have heard about the gut having abundant microbiome. I'm talking about your skin has a microbiome, your oral pharynx has a microbiome, your gut has a microbiome, and the genital urinary tract has a microbiome. And that is different between men and women. And that microbiome is with all of us. You add up every bacteria that contains the microbiome, they're in the range of being 100 times greater in cell number than every cell in your body. You are carrying 100 times your cells in the microbiome, and we're just starting to unravel how important it is in immune repertoire, in immune regulation, and interacting with your genetics. But it's clearly going to be playing an increasing role as we go forward. Now, the topic I want to address are what I would like to call cholestatic variants or overlap syndromes between primary biliary cholangitis and autoimmune hepatitis. And I'm going to abbreviate them as PBC, which you're familiar with, and I'm going to call autoimmune hepatitis AIH. Now, here's AIH. As a disease, it has the potential from the literature to inflict an overlap in a patient with PBC where they have concurrent features of both disease, somewhere between about 1 and 10% is what you're quoting. And if you just sort of put your ear to the ground, you're going to hear increasingly, as I told you, things are sort of spinning along like a top, and that increasingly people are sort of fixated on about 10%. Not sure that's right, and I'll explain why. Now, what is a cholestatic variant syndrome? Well, we could say it's the coexistence of an autoimmune hepatitis-like features with cholestatic features that resemble PBC, or there is one for PSC, not the topic for our discussion. And we want to call it this because the physician then will be prompted to look for all the reasons that those two things could be there. And so they have to look at why the cholestasis may be worsening. They have to look for other issues. An overlap syndrome clearly implies the coexistence of autoimmune hepatitis with either PBC or PSC. We have a group that has been working in this field for about 50 years now called the International Autoimmune Hepatitis Group, and I'm one of the 3 North American members of that group. And we looked at a consensus definition based on the entire literature review and concluded that we ought to really define an overlap syndrome as an autoimmune liver disease with one or more features of another autoimmune liver disease, based on the features, rather than getting hung up in the weeds to say that we have 2 distinct diseases that have coexisted. Now, unfortunately, once we say overlap, you kind of close the book. So that's what I have, and you don't look further, which we want physicians to do better. Now, a misdiagnosis of that has become rampant in clinical practice. And I want to kind of unravel what I mean when I say that, because of how we are applying things that were never studied or validated to be applied. So what are the diagnostic criteria for AIH? First, it is a diagnosis of exclusion. That means you better be sure that things that can look like AIH don't exist in a particular patient. And that is at the clinical level and at the serologic level with autoantibodies and at the biopsy level, which is required actually for the diagnosis of autoimmune hepatitis. We have revised and simplified diagnostic scoring systems, and liver biopsy is required for the diagnosis. Now, this big picture is the autoimmune hepatitis revised diagnostic criteria, and what I call your attention to, there are clinical criteria in terms of female, will add 2 points. The ratio between your alkaline phosphatase and your AST or ALT, if it's high, that subtracts points. And you have gamma globulins. You have the autoantibodies. If you're positive for anti-mitochondrial antibody, it subtracts points because that is something that is relatively rare, very rare, in autoimmune hepatitis. Viral markers would subtract points because that's one of the diseases that can mimic an autoimmune hepatitis. We have whether you have drugs, alcohol. We look at immunologic diseases that are associated, like thyroiditis that will lead to hypothyroidism and others. We look at the other autoantibodies associated with the disease. And then we have all sorts of points that you can add for particular features of a liver biopsy. So the bottom line is that we can tally up all these points and come to either a definite or a probable diagnosis. Or if you're less than 10 points, it's very unlikely that you have autoimmune hepatitis. Now, that's pretty cumbersome. I mean, it's hard for many people to spend the time and do that rigorously. So we as a group put together and published and validated a more simplified scoring system. Here, you basically have your anti-nuclear or smooth muscle antibodies, or your liver kidney microsomal antibodies, or your anti-SLA. We lump all the antibodies and we give points. You have your immunoglobulin level, whether it's elevated or not. And then you have histologic features that we basically said compatible with or typical of. And typical would be several of those features to which we gave points on the prior slide. And then the presence or absence of viral hepatitis. And obviously, if you have viral hepatitis, you want to make sure that you don't get extra points. And then the diagnosis is made at 7 or greater. Now, this was simplified and this was validated only for people with typical autoimmune hepatitis. That's what this score diagnoses. It doesn't take somebody coming in the door with viral hepatitis or another autoimmune disease or a drug-induced liver injury, because I can take the same things and I can find these elements. So I can take drug-induced liver injury and use this score and conclude that it's autoimmune hepatitis. That would not be appropriate, but I could do that. And this is the fundamental score, this score, that has been used, and I have to say misused, in order to say whether a patient with PBC has autoimmune hepatitis overlap. Now, you see it does have biopsy. Histologic features refer to biopsy. It also has antibodies. And I want to go over the issue that many of you have, and I think continues to confuse our field, and that includes gastroenterologists and even some hepatologists, and that is that in autoimmune hepatitis, anti-nuclear antibodies are the rule rather than the exception. There's a type 1 autoimmune hepatitis. It's 95% of all that disease state, and it's characterized principally by anti-nuclear antibody and or smooth muscle antibody. But the anti-nuclear antibodies, when you look at them, they come back at a titer, meaning how much antibody you have, and it has these kinds of patterns. The anti-nuclear antibodies also exist that are specific for PBC patients. They are not found in autoimmune hepatitis patients. And this is the SP100 specificity, which gives a nuclear dot pattern, or the GP210, which gives a nuclear 4 pattern. And then we have the anti-centromere anti-nuclear antibodies, and this is associated when a PBC patient has associated scleroderma-like disease. It is really an antibody telling you about the scleroderma-like disease. And in fact, it's about 98% specific that it does that and tells you. So having anti-nuclear antibodies in PBC occurs in around 60% or more. So it then depends on which ones. Now, it doesn't mean that you can't have these, but it certainly means that if you have those, all that ANA is telling you is that you have PBC. And so we like to actually test for these. Has anybody in the audience been tested for those specific antibodies? Kind of raise your hand, get an idea. So I have several people, and one of the problems of testing has been everybody trying to find out where you can get the test done. And this is something that we're trying to get that word out because they are available and they're FDA-approved tests, but they haven't been all that well utilized. They can be also important in the doctor-patient relationship because they portend certain things of prognosis, and certainly with the anti-centromere to look at issues that may be corollary issues of having a scleroderma term like syndrome. Now, this is a slide that shows the typical biopsy of a lesion in autoimmune hepatitis, which needs to be characterized by the pathologist, not by you. It's called interface hepatitis. What that means is here is a sleeve of connective tissue in which the vascular structures and the bile duct lie, and here is inflammation, but here's this indistinct border where these cells here in the pink, they're all hepatocytes, and these little cells are all inflammatory cells. So the interface between this should be sharp, should be just a sharp border, and you have hepatocytes. You don't see a sharp border. You see that the interface has hepatitis, inflammation of the liver is what that word means, just like tonsillitis means inflammation of your tonsils, appendicitis, inflammation of your appendix. So hepatitis is a generic term, and here you see it. But this kind of penetration of inflammation into the liver cells is interface hepatitis. Now that occurs in lots of diseases. And when you find that on a biopsy, it is not synonymous with saying that the diagnosis is autoimmune hepatitis. And I'm going to show you that in PBC in just a moment. So let's get back to this issue of the overlap. When we did the work with the International Autoimmune Hepatitis Group, we came up with 5 potential explanations for a cholestatic variant syndrome or an overlap syndrome. And you can see them. You've got sequential or concurrent occurrence of 2 distinct independent autoimmune diseases. You have a distinct pathologic entity that is a combination differing from either of the individual diseases. You have a midpoint in a continuum where autoimmune hepatitis would go to a cholestatic autoimmune disease like PBC, or PBC at a point in time would transition to an autoimmune hepatitis, that it could be one of several heterogeneous expressions of autoimmune hepatitis, or it's a primary autoimmune liver disease with one or more features of another disease. Well, I kind of gave the answer away earlier, and that is that we feel that the expert data and analysis of the available data favor this explanation as to how we would define it. Now, that gives us wiggle room to understand that if we have features, we want to monitor that, we want to further understand it. It does not mean that one has to immediately try to address it with immunosuppression, because immunosuppression carries with it the context that you're going to be on some additional form of drug for a very prolonged period of time, and we want to be right for each and every individual before we make that decision. Now, this is a liver biopsy of one of my patients with PBC. Here is a bile duct, and I've got enough parallax that it's hard for me to see it, but I think you can see these small cells are the lymphocytes that have invaded that bile duct and are destroying the individual lining cells of that bile duct. That particular lesion has been called non-suppurative destructive cholangitis. Nobody remembers that, but that's what it was called. But we now call it lymphocytic, because those little inflammatory cells are lymphocytes, cholangitis, inflammation of the cholangials. So lymphocytic cholangitis, principal lesion of PBC. There's no doubt in this patient highly positive for AMA, but look at this. I've got all of this interface hepatitis. So how do I explain that? Do I immediately say, oh, the pathologist said you have interface hepatitis, you must have an overlap? That would be mischaracterizing it. Do I go and say, oh, I want to break that simplified scoring system out and say, you've got interface hepatitis, okay, do you have anti-nuclear antibody? Check. It gives you some points for that. You got the biopsy, okay, what are the gamma globulins? We're good to go. I think you meet criteria on a simplified system that was never validated for that purpose. Well, the answer in part to those questions is on this slide. I really want to pay attention to this one. This is an old study. This was published in 1980, but it was a very important study because it had about 236 patients, the largest number that had ever been brought together in North America and Europe for a trial. And what they did the trial with was azathioprine. Azathioprine is an antimetabolite that keeps lymphocytes from dividing rapidly. Well, it keeps almost every cell that divides from dividing rapidly, which is part of its toxicity. But azathioprine was a known immunosuppressant, and they randomly took people and assigned them to be on azathioprine with PBC because there was no other treatment at the time. It was all pre-ursodeoxycholic acid. There was no therapy. And they had the other group take a placebo. And everybody had a biopsy every year for 4 years because this was a biopsy endpoint to see if they were improving the disease. Well, azathioprine didn't work. So that allowed them at the end to say, look, we can put all 236 patients together and we can look at all the biopsy characteristics over time and understand what was happening in a 4-year progression of disease under intense scrutiny at all these different investigative sites, which unfortunately didn't show a benefit from this drug. That's what this slide shows. So here's a graph, and it starts with 0, and it goes to 100, and you see this curve. And this is really approaching nearly 100% of all the patients in that study over those 4 years developed biopsies showing interface hepatitis. This is thoroughly PBC. So you wouldn't say, gosh, 100% of people with PBC develop overlap with autoimmune hepatitis. But unfortunately, this is partly why we're saying that in modern practice. The biopsy is done because the ALT and AST are elevated. It comes back saying interface hepatitis, and it can be misconstrued. Interface hepatitis is an obligatory step in the progression of PBC. And it's one of the steps that can be contained when you respond to ursodeoxycholic acid, our current therapy, and can be contained in those that have a partial response or a non-response with the addition of obeticholic acid. So you've got to understand that this is part of PBC. It's not just for autoimmune hepatitis purposes. Then we also have that in the portal tracts, those elements that carry the blood vessels and the bile duct, little sleeves of connective tissue, just like limbs of a tree going into their fine branches, that the B lymphocytes actually contain abundant immunoglobulin. So having immunoglobulin elevations occurs in PBC too, because that was one of the criteria on the prior slide of the simplified criteria. So when we get back to it, what do we do with this? What is the number? How diligent does somebody have to be to make that diagnosis? And in particular, having made it to add immunosuppression to ursodeoxycholic acid. We are still searching, but the most informative study that was done was that of the Mayo Clinic cohort, followed between 1996 and 2006. 1,476 extremely well-characterized patients with PBC, followed long-term, treated with urso, all the things that we can validate their diagnosis. They then looked in every manner possible, including liver biopsy, and identified only 8 cases, 0.54%, who had developed an autoimmune hepatitis overlap syndrome that could be substantiated on the basis of all known criteria. This is pretty different than 10%. So the answer is somewhere probably in between. And we need this issue of diagnostic criteria that are based on very disease-specific, meaning disease-specific for PBC, disease-specific for autoimmune hepatitis, in order to crack this open further. We need actually a test that says the mechanism in your liver is autoimmune hepatitis. That's what we lack. We just basically have the impression that it has features of, and therein lies our conundrum. And we do need to do an increasing amount of work in this. So this basically says that only Alan was prepared to acknowledge the elephant in the room. And it is an elephant in the room for all of us that are in practice and all of you who have a PBC. Now, let's take it a step farther. With PBC, everyone in this room wants a cure. We want a treatment. We want a cure. We're advancing our knowledge continuously in autoimmunity in general that we hope will eventuate in that cure, which would be to tell your immune system to stop recognizing and stop remembering your bile ducts as being a foreign place to attack, to reestablish the equilibrium that you were born with that said that this is self, and I'm not going to damage it. I'm only here as an immune system to protect it. We're not there yet, and a lot of work is going to be required to get there. But between now and then, what we do want is that you have treatment, and that the treatment is capable of having you all live very productive lives that have high quality and have a longevity that is not impacted by premature events caused by liver disease, cirrhosis, complications of cirrhosis, or the need for liver transplant. And we are partly there in the URSO era. This is not a talk to show you other slides that I could, but we have incontrovertible evidence in the United States and elsewhere that we have reduced liver-related deaths due to PBC in the URSO era. We have reduced hospitalizations. We have reduced the number of transplants being performed for this disease. But as long as we have any of that, we're not doing well enough. And that is the segue for my last remark, and then I'll open it up for questions. So my last remark is to have you understand that many things about the immune system have been identified, and many things that kill cells or allow cells to go through stress and to just die in an adverse environment have been identified, and mechanisms and drugs have been developed that have the capacity to alter that, to inhibit that process. It's going to be through clinical trials and participation of patients with PBC that we're going to make the next progress, which is to prevent those liver-related deaths, prevent the progression to cirrhosis in everyone, prevent the need for a liver transplant. And I have over some flyers, I think I have about 100 copies, I may not have enough, that show you in our research center, which is just one among many of the multi-centers that are around this country, the 5 clinical trials currently enrolling patients with PBC. And I would urge you to look into these. It's a personal decision. It's a voluntary process of participation. You'll hear a little bit more about the process and what a clinical trial is and what informed consent is. But I'd like you to, all of you, take a look and see, is there a fit here? Because we need to make this progress. That doesn't mean every drug we study will be the right one. But every time we can get a signal that maybe it's the wrong one, just like Edison, who had to get rid of all these failures before he could find the right one to be the filament in a light bulb, we're going to find it. So I just urge that you consider participation as something that you may want to do, entirely voluntary basis. So I thank you for your attention. I'm ready to take questions on this or any other topic of PBC. The first question is from someone who has 4 people in my family with PBC. Do you think we can get in a gene study? How do I find one? Well, first, let me say that we know that PBC has one of the highest incidences as a familial disease of any autoimmune disease. We actually know that now from prior gene studies. We know that in identical twins, where environment and everything else has to play a role, and as I said, environment can impact twins differently, especially the immune system. 2 twins can diverge in their immune repertoire fairly rapidly after birth. We know that the finding of disease in identical twins is much higher than in any other autoimmune liver disease. Those are the things we know. Being part of a larger set of genetic studies, I can, when we break or during lunch, I can put you into people that are banking and working on an international basis to enlarge the population of PBC patients. But we have a lot going on, particularly with the participation of the European countries with their national healthcare systems, where the database exists in a national form of identification of patients with a specific diagnosis, that much of this is going on. We're going to have much more of an answer and an understanding of the relationship with genetics, but those things I told you are true. So as impacting as this is for the person who sent me this question, this is a fact. It is genetic to the extent that it's much more common in families than it is randomly, and it's much more common in identical twins.
This question's on UTIs. Why are they so prevalent with the people, the PBCers, and what's the best way to treat it? How can we treat it?
UTI is urinary tract infection, and urinary tract infection has been looked at from a variety of perspectives. First, if we look at just the sex ratio of this particular autoimmune disease, PBC is number 2 on the entire spectrum of all autoimmune diseases in terms of having a female predominance. So you're sort of at 9 to 10 women per 1 male in this disease. Within women, compared to men, one has an increased frequency of urinary tract infections. And it has to do with that genital urinary microbiome. It also has to do with the fact that women have a single sphincter that prevents urine from flowing from the bladder out through the urethra for urination. Men have 2 sphincters. Unless they've undergone a prostatectomy, they'll lose one, but they'll still have the one that women have. This is one of the issues that women face, especially after childbirth and with age, that they may have some stress incontinence, cough or sneeze or something. They can't control that sphincter as well. This means also that they have a short urethra. And the urethra is obviously part of the microbiome environment. The entire vulva, vaginal area, and the anorectal area has access really to that urethra. And a short segment up is the urinary bladder holding urine. So women in general are more prone to urinary tract infections. If we look at PBC, there are a lot of data that have come, but not from huge databases, I have to say, that would suggest that they can't really pinpoint that the UTI frequency is greater, that they can pinpoint that there are a lot of UTIs. I'm not sure what that answer is, but when you look at this, the treatment of UTIs has advanced considerably, particularly those that have chronic recurrent UTIs. And I really have to refer you to the people that deal with that, which are their specialists in infectious disease and also urology. I'm not really capable of making much progress in answering. There's no magic bullet of treatment that one does not want to have in a chronic recurrent urinary tract infections.
This question deals with AIH and recovering from it, basically being in remission. And does it recur with AIH forever? This person is on Immuran and Hepatitis. So is it something where it reoccurs after it goes into remission?
So let's take this one step at a time. I'm going to take it from the autoimmune hepatitis side, and then I'm going to take it from the overlap side. The autoimmune hepatitis story is that many patients who are capable of going into remission are put into remission but using steroid combined with azathioprine. Azathioprine's old trade name was Immuran. Those are identical. Azathioprine and Immuran are the same. The azathioprine story was that it was added and it gained favor because it allowed us to use a lesser dose of steroid. Everyone who's ever taken steroids or read about taking steroids knows if you take high-dose steroid, you are going to have steroid side effects. And in autoimmune hepatitis patients, that was about 67% within 3 years had significant steroid side effects when it was used as the only therapy. So when you added the azathioprine, it allowed you to reduce the dose of steroid, because now you're hitting the immune system with two different sites, two different drugs. That was its benefit. And we also learned that you could get down the steroid dose, and as you march that steroid dose down, there were people that were maintained in remission solely on azathioprine alone, which we have seen, it's an observation, and we know that the azathioprine appears to be holding everything in check. Now, such patients were at one time thought to be perfect candidates for recurrent attempts to wean them off azathioprine and see if the disease would not flare or recur. And unfortunately, when you come off all immunosuppression with autoimmune hepatitis, there's about an 88% chance that you will recur within 3 to 6 months. And the long-term prospect that the other 12% will be without disease is not good, because about another half of them, when observed, may again have a repeat disease. Kind of stands to reason if your autoimmune potential is now uninhibited. Remember I said it recognizes, it responds, and it remembers? It's the remember part that hasn't gone away. And that's part of what we want in our immune system. We want to have a repertoire that has remembered things we've seen before, can fight them aggressively if seen again. So I have to say that when you withdraw, it's only a tiny minority would be able to do that without a flare of disease. Now, we also once thought, well, why not try because it's benign? Then came a landmark paper from the Mayo Clinic, and it retrospectively looked at all their data and found, somewhat to the surprise, that it wasn't benign. That for every time you were withdrawn and you relapsed, especially if it was more than one time, you marched up a new scale of risk of developing cirrhosis and risk of undergoing a liver transplant for autoimmune hepatitis. So we now have the thought that in certain circumstances and in certain patients, we may try a withdrawal, but we'll never probably try that more than once. Now, does this apply to what I was discussing in the Ovelap syndrome? It really is anyone's guess, because I can tell you that what I was showing you for that interface hepatitis is the natural history of disease. In the URSO era, that for responders to URSO is prevented. For those that might have a biopsy showing that, it doesn't mean that URSO alone might not be sufficient for it. So if I were to add a drug, azathioprine or anything else that's immunosuppressive, and then over time withdraw it, I in theory might be successful if I didn't need it in the first place. I don't know. It's a part of a question that can't be answered because you can't control for it. So I think that this issue of whether one can be withdrawn from it is still unanswerable. Certainly one wants to be on the lowest dose of immunosuppressive medications that are consistent with keeping you in a biochemical remission.
We had a question regarding overlap between PBC and common variable immunodeficiency, as well as overlap between thyroid disease as well as stage 2 kidney disease. Any thoughts around kind of overlap?
Well, I think that I don't think overlap's the right term there. I think what we ought to be thinking as a paradigm of associations. I started the talk by telling you about all autoimmune diseases. And all autoimmune diseases have things in common. One of those is that if you have an autoimmune disease, you have a potential to have another associated autoimmune disease, or even more than one. If you look, starting with the one that would be most common, thyroiditis, Hashimoto's thyroiditis, often occurs in a very asymptomatic manner, and then insidiously will lead to a hypothyroidism because of the destruction of the thyroid gland. And this, of course, can lead to misdiagnosis of the origin, say, of more progressive fatigue. Other things would be attributed perhaps to the liver disease, and that's why we would like everyone in our practice to be monitored for a thyroid-stimulating hormone every year, because the frequency of thyroid problems and hypothyroidism is great enough to justify that. So that's an associated disease. Then you look at the issue of association with kidney disease. There is no specific known association with having kidney disease. The issue of kidney disease and associations with autoimmune diseases do exist for some other diseases where complexes of antigens, the self-proteins, bound to antibodies, your autoimmune potential, they form a complex, and this can gum up the works in kidneys. And this is very common in systemic lupus erythematosus as an example of a disease. When we look at chronic kidney disease in the United States right now, those early stages of chronic kidney disease have many different origins, but there are three that nephrologists are paying most attention to. One is the potential of toxicity for non-steroidal anti-inflammatory drugs like ibuprofen and naproxen. So this is your Advil, Motrin, and Aleve. The second has to do with diabetes and pre-diabetes causing microvascular changes. And the third is that with metabolic syndrome associated with obesity, pre-diabetes, one can develop hypertension. And so unrecognized hypertension combined with a pre-diabetic or diabetic state is not well controlled can contribute. So these are things that are more general topics for America, but given our enlarging size as Americans and this metabolic syndrome, that would be more likely than an immune complex phenomenon. Then we get to the common immune variable immune deficiency. I know of no specific association. I do know that there are some people individually that have this, and we have seen it. But the issue is it association or is it acquired immunodeficiency that just came as its own, and maybe it would have come without the presence of PBC? I can't answer that in terms of mechanism.
The next question we had is PBC and AIH, does that increase the likelihood of transplant? I would add in hepatocellular carcinoma as well. Does it increase those chances for either?
Well, that's a terrific question, and I have to say that the data available in the literature do not answer those two questions adequately. What we can say is that anti-nuclear antibody or anti-centromere antibody or GP210, the specific PBC antibody, all as a test result say that the person is at more risk for progression of the PBC. It doesn't say whether they will progress. So why did it turn out that way? Well, among the ANAs are ones that we believe and can show in the literature are fairly benign long term. And those would be the ones that are giving us the typical homogeneous and speckled patterns that we see in ANA positivity throughout different disease states and even among normal people as they age. The GP210 portends a worse potential prognosis unless you're treated and you respond. And if you're treated and you respond, its prognostic significance in that you're going to do worse goes away. It's controlled by the response to ursodeoxycholic acid alone or in combination currently with obeticholic acid. If we look at the issue of the progression, part of the progression, they take the person who is untreated or not responsive to treatment to cirrhosis faster. That would be true, a true statement. Once you have cirrhosis due to anything, PBC, autoimmune hepatitis, hepatitis B, hepatitis C, anything that might cause cirrhosis is a risk factor for the development of a hepatocellular carcinoma. So the consequence is that something that might go down and put you to develop cirrhosis that you might have had you responded to therapy or been diagnosed and adequately treated before that time be prevented. Once you have cirrhosis, you have that risk. Now, the good news is that with both autoimmune hepatitis and PBC, it is extremely hard to find good data that suggests that the incidence is significantly above about 1.1% per year. A really low incidence. We look at hepatitis C and cirrhosis, the rates are about 3.5, the most recent publication complications, 7.8% per year. Huge risk for hepatocellular carcinoma, not in PBC or autoimmune hepatitis. But I can't tell you because I hopefully convinced you that we have some overlap diagnoses that may not be entirely accurate. So trying to find the ones that are most accurate and saying what's the risk in that group